Good morning. My name is Tullio Ghi. I'm a professor of obstetrics at the University of Parma. I'm so pleased to give start to this new project with Philips regarding all the information, all the details to perform a detailed scan of the fetal Bennett first trimester. I'm here with my two colleagues, Professor Dall'Asta and Dr. Volpe, working in my unit, and I will give the word to them.
Hello everyone. As you will see, thanks to the increase in continuous improvement of the technologies, both 2D and also 3D and also Doppler technologies, now ultrasound allows to obtain images with increasing details, and it is our goal to show you how you can obtain the best from these new technologies.
Yeah, well, we've been working to that, and starting from this concept, we came up very recently with a state-of-the-art review, trying to find out what is a first trimester neurosonogram, just trying to go with the same multi-panel approach of the second trimester, but just moving it into the first trimester brain anatomy. And this project is actually based on just this.
We start now with a description of a video clip obtained at first trimester in a normal fetus. As for any type of brain scanning, also at first trimester, we start with the basic axial view of the fetal head and brain. On this sweep, very narrow sweep of the fetal head and brain obtained at first trimester between 11 and 13 weeks of gestation, we may appreciate a lot of data and information that can be used to confirm that the fetal anatomy of the brain is normal and we can exclude major abnormalities. First of all, we need to assess the contour of the fetal head, the integrity of the skull, in order to exclude the presence of neural tube defect, the most severe one, the acrania, but also other types of more subtle abnormalities like cephalocele and cephalocele. It is quite obvious to notice that there is some mild degree of indentation of the external parietal bone at the level of the conjunction with the frontal bone. This is due to the presence of some unossified space, which are the fontanelle, especially in this case actually is the coronal suture, which is transversing the fetal head from one side to another. After having assessed the profile and the contour of the skull, we concentrate on the content. It's very important to evaluate the presence of a midline which divides the brain into equal parts, which are the two hemispheres of the brain. In this very early stage of pregnancy, the hemisphere in the most cranial part are mostly filled and represented by the choroid plexus, which have the appearance of the two wings of a butterfly, and they are clearly included within some black spaces, which are the lateral ventricle. At this stage, we can clearly notice that there is a certain spatial relationship between the area of the choroid plexus and the area of the black space, the ventricles, where the coronal plexus are contained in. And it is possible to quantify the ratio between the area of the coronal plexus and the area of the lateral ventricles, or to quantify the ratio between the area of the coronal plexus and the diameter of the fetal head on the circumference of the fetal head. When this ratio is abnormal, that means that this ratio is reduced, the area of the coronal plexus is reduced compared with the area of the black space represented by the lateral ventricles, or the ratio between the area of the coronal plexus and head circumference is reduced, we may suspect very early in gestation the presence of ventriculomegaly. There are few data that have been produced on that, and it's certainly a major area of interest. When we move a bit caudally with our sweep, with the probe, we may detect the presence of these two black triangles, the thalami, and this is actually the main structure which constitutes the diencephalon. The midline has a very typical appearance because it has two major areas of interruption. Anteriorly, we can see the very early appearance of what is called cavum septum pellucidi, which is a structure very important to be seen later in the station to assess the normal cleavage of the brain and to exclude abnormalities of the most important commissural structure, which is the corpus callosum. More posteriorly, we see another black box, which is a bit more squared compared with the cavum septum pellucidi. That box is, just let me go here. This box is the Sylvian aqueduct, and is a structure that is very important and very prominent, especially at first trimester. Is one of the fluid cavity where the cerebral fluid circulates, and its anatomic characteristics, and especially its spatial relationship with fetal head contour is considered an indicator of the normal anatomy of the brain. There are some data suggesting that when this black squared area is too close to the posterior scalp, to the occipital bone, this is considered a possible site, very early site of open spina bifida. It is like an indicator of a crash between the brain and the skull, and from some very prominent authors, this site has been called crash sign, and you will see in the next video clip obtained on different plane, which are the other direct sign of spina bifida. This is an indirect sign that can be obtained on the axial plane, together with the fact that in those circumstances, the fluid area where the coronal plexus are contained, the lateral ventricle, is less represented, and we have a subjective impression of dry brain. So dry brain together with the Sylvian aqueduct too close to the occipital bone, crash sign, should be investigated as possible marker of open spina bifida. it is possible to see a very subtle black slit here. This is the third ventricle, which is again another typical fluid space that we can see within the brain. And we have also the possibility to have a look at some early structures of the posterior fossa. We cannot clearly see as it happens in the second trimester, the cerebellum in its entire structure. We can barely see the two lateral hemispheres as some structures of the posterior fossa, but the best view to assess the cerebellum and the posterior fossa structure are the sagittal and the coronal view, which will be displayed and commented from my colleagues later on. We cannot comment too much regarding the profile of the external surface of the brain, of the cortex, because we know that the structure of the cortex is very rudimental, it's completely smooth at this stage. Also, it is very difficult to comment regarding the morphology of the sylvian fissure. You can notice that the proximal hemisphere at ultrasound insonation can be seen as clearly as the distal one due to the fact that the parietal bone is not so well ossified, so the shadows that are casted on the proximal hemisphere are less pronounced compared with what happened at second trimester and later on in gestation.
Thank you, Tullio. Thank you very much. We can go now on a different approach. We can talk about coronal views, and this is an example on how the fetal brain in the first trimester could appear on coronal views. So this is a quick sweep of coronal views, but we have different views by coronal approach, similarly to what we can see in the second trimester. So I can stop on specific views just to comment on that. So the most anterior one is the transfrontal coronal view that is actually here, where you can see the midline echo, that is actually the interhemispheric fissure. On the two sides, you can see the anterior horns of the lateral ventricles. Just underneath that, you can see the frontal bone. This is actually the roof of the orbit, the part of the frontal bone just above the orbit, and this is the orbit, and you can see the eye lens as you sweep or move from the front to back. While we are moving backwards, sometimes in the transfrontal view, we can see just the most anterior part of the choroid plexuses that are actually inside the lateral ventricles. But very interestingly, we just go back, and we just get to the point of the basal ganglia. So this is the transcaudate coronal view. The caudate is one of the ganglia, and you can see the basal ganglia here and here. Just in between them, you can have the third ventricle. It's very clearly depicted in this view, and it is black fluid-containing ventricle as expected. It is very nice to see how clear is in the first trimester the foramen Monro just above the third ventricle on the midline. So third ventricle, the foramen Monro where the two choroid plexuses are joining, and then above that there is the interhemispheric fissures. On the sides we have anterior horn of the lateral ventricle here and here, choroid plexuses inside the ventricles, joining in the middle, in foramen, at the level of the foramen of Monroe, and on the two sides, just here and here, we have the basal ganglia. It's very interesting to see how nicely could be visualized at this very early stage the ganglionic eminences. This thickening of the top of the basal ganglia just on the floor of the anterior horns of the lateral ventricle are the ganglionic eminences that have been recently described also in the second trimester, and these are the areas where few neural cells are coming from and migrating toward the cortex. So they're having apparently key role in the developing of the brain and the cortex in particular. And if you just move backwards, we go to another coronal view, just moving and continuing in continuity with the transcaudate, we can start seeing two different structures appearing on our screen that are actually the thalami. So you see the two oval-shaped structures, hypoechoic, one here and the other here, are the thalami. In this apical view, actually you can see it like that. Of course, we are parallel to the interhemispheric fissure that is not visualized in an optimal way, but other structures that are perpendicular to the ultrasonic beam, like the ganglionic eminences, are visualized much better as we are approaching through the sagittal suture. And just going backwards to the thalami, you can still see them as a two oval-shaped structures, symmetric, one on each side of the midline, one on each side of the third ventricle that is still here, anechoic, just in the middle of the thalami. And it is very, very nice to see how here the lateral ventricles are changing their shape. They're changing their shape as we can see the temporal horn that is actually on the sides. This line is lining on the sides of the thalami. You can see the choroid plexus coming down and the ventricle coming down on this view, specific view, on the side of the thalami, on this and this sides. So we can see now the temporal horns. And as we get slightly backwards, you can still see the shape of the lateral ventricles, temporal horn, but now we are behind the thalami and we are getting into the cranial posterior fossa. This is the quick sweep of the views that I just showed you, but I want to highlight how sometimes if you just change your approach, you can have a different view of the structures. Sometimes more nicely you can see, for example, the interhemispheric fissure here going from front. You see the interhemispheric fissure here, the frontal horns with the choroid plexi, the orbit and lens, the frontal bones. Then you go backwards and backwards, and you see less clearly the ganglionic eminences and the basal ganglia, but you see a little bit better as you are insonating better. The third ventricle, you see here the foramen of Monroe, you see here how these two choroid plexuses are joining, but then you go backwards and you see a bit better here the thalami on the two sides of the midline and the ventricles here, and on the sides the temporal horn of the lateral ventricles here and here on the sides of the thalami, and the third ventricle still in the middle. And then you go to the cranial posterior fossa. The cranial posterior fossa actually is very nice to be described and depicted. The main structure you can see here very crucial structure is the fourth ventricle, and just above the fourth ventricle you can have the aqueduct of Sylvius. But I think that in the next slide this could be depicted a bit better. And as we go backwards, we go from the third ventricle. This is how the fluid is connecting the ventricles. There is the third ventricle in front, and then you have the aqueduct of Sylvius, that is this structure here, and then the aqueduct is connected with the fourth ventricle by the isthmus. So if we want to highlight these structures, you have the aqueduct of Sylvius, and then the isthmus is this small little line here, and then the fourth ventricle here. The fourth ventricle has a typical rhombic shape, as you can see here, a little bit elongated in the lower and most caudal part. That is actually, as we will see better in coronal view, in axial views, that is actually the Blake pouch here. But let's get back to the aqueduct and to the fourth ventricle. You have very nicely the aqueduct that is the most anterior anechoic structure of the cranial-posterior fossa, and it is just here in connection with the third ventricle. At this level, we are still in front of the fourth ventricle, and you still don't see the fourth ventricle. This is the most anterior coronal view of the cranial-posterior fossa. You don't see the fourth ventricle here because you just see the brainstem. You just see the brainstem, and actually, if you want to be more specific, this is the midbrain, part of the brainstem. This is actually the tectum, and this lower part is the tegmentum. And then you see here on this side, and again on this side, the rudimentary hemispheres of the cerebellum, and this means that we are here at the level of the pons, and this lower part is actually the medulla oblonga. And while you are getting backwards, you just see more clearly the fourth ventricle here. Actually, in this frame is probably nicer here. Just see it. Fourth ventricle, rhombic shape. The lower part is the Blake pouch, and above it there is the aqueduct surrounded by the midbrain tectum. On the two sides, the rudimentary hemispheres of the cerebellum. Just below the rudimentary hemispheres of the cerebellum, you have these white dots. These white dots are actually here and here, the choroid plexus of the fourth ventricle. As we go backwards, we are just behind the fourth ventricle, and this is the last coronal view, the most posterior coronal view of the cranial posterior fossa, and you have the hemispheres joining in the rudimentary cerebellum, and you can you can have just here, this one here, and you can have the fourth ventricle just here, the fourth ventricle choroid plexus just here. The two halves are joining in the middle, so rudimentary cerebellum. So you have the choroid plexus of the fourth ventricle, and just underneath it you can have the most posterior and caudal part of the fourth ventricle here, the Blake pouch. And I think we have done with coronal view, and we can start with the next section just in a second. Thank you.
So we now move on to the sagittal views of the fetal brain in the first trimester. We are starting with this scanning view. I'm sure we are all familiar with this scanning plane, which is the one used by sonographer, radiographers, and also fetal medicine specialists for performing the combined screening test in the first trimester. This is actually a clip obtained using a high frequency probe, allowing, as you can see, a very detailed and crisp characterization of the structures, which can be imaged on the scanning plane in the first trimester. I will not spend long time in saying that this is, of course, a normal case. You can see the chest, the neck, the face, and the head of this first trimester normal fetus, and I will not spend long time in saying that looking at the cranial structures, for example, this is a normal forehead here, this is a normal nose with nasal bone here, this is the maxilla, this is the chin, and looking at what we commonly measure at this gestation here, you can see there is also a normal nuchal translucency here. But looking at the main goal, the main topic of this recording, which is the fetal brain in the first trimester, I'm going to describe what you can appreciate at this gestation in the fetal brain using this scanning plane. Moving from anterior to posterior, you can see here this is the cerebral folks, and posteriorly here you can see this is the encephalon, and here at the back again this is the mesencephalon. But actually, looking at the scanning plane in the first trimester, I think the most important informations can be obtained with respect, of course, to the normal versus abnormal anatomy of the fetal brain in the first trimester, can be obtained looking at the most posterior part of the fetal brain corresponding actually to the cranial posterior fossa. And this is, as I said, a normal case. And as you can see here, under normal circumstances, there are 3 anechoic spaces at this level of the cranial posterior fossa. The most anterior of these anechoic spaces is the brainstem. The intermediate anechoic space is the intracranial translucency, also called the fourth ventricle, and posterior to the fourth ventricle, the most posterior anechoic space here is the cisterna magna. Again, looking at the borders of each of these 3 anechoic spaces, actually the brainstem, the most anterior one, is delimited anteriorly by the anterior wall of the brainstem and posteriorly by the posterior wall of the brainstem. The fourth ventricle or intracranial translucency here is delimited anteriorly by the posterior wall of the brainstem and posteriorly, but this anechoic, by this high echoic structure, which is represented by the choroid plexus of the fourth ventricle, and the most posterior anechoic space, the cisterna magna, is delimited anteriorly by the choroid plexus of the fourth ventricle and posteriorly by the occipital bone. So this is what we need to bear in mind looking at the normal anatomy of the fetal brain in the first trimester with respect to the cranial posterior fossa. But if this is normal, what is abnormal? Actually, it is important for you to bear in mind that if you cannot see the 3 anechoic spaces, but you can see only 2 out of 3 of the anechoic spaces, this is a problem. This has been reported consistently in the literature by several authors, the fact that the absence of one of the 3 anechoic spaces, so the visualization of only 2 out of 3 anechoic spaces, is associated with pathologies involving directly or indirectly the cranial posterior fossa. Actually, the first observation was that describing an association between the absence of the intracranial translucency, also called, as I said, the fourth ventricle, and the diagnosis of open spina bifida. Actually, this, from a pathophysiology point of view, when you cannot see 3 anechoic spaces and there is an open spina bifida, actually the missing anechoic space from a pathophysiology point of view is not the fourth ventricle, but is the cisterna magna, because we know that when there is an open spina bifida, there is a downward displacement of the cerebral structures, including the structures of the posterior fossa. Following the first observation describing this association between the absence of the intracranial translucency and open spina bifida, some other authors tried to make it simple and described another quantitative parameter, which was called the ratio between the size of the brainstem and the distance between the brainstem and the occipital bone, basically what is called the brainstem to occipital bone ratio. And this, of course, as I said, it describes the ratio between the anteroposterior size of the brainstem and the anteroposterior distance between the posterior wall of the brainstem and that between the posterior wall of the brainstem and the occipital bone here, which is this hyperechoic structure here. Very simple marker, because when we cannot see three anechoic spaces and the size of the ratio and the ratio between the brainstem and the distance between the brainstem to occipital bone is above 1, this has been consistently associated with a diagnosis of open spina bifida. Actually, the absence of, it is important for you to bear in mind that the absence of one of the three anechoic spaces is not mandatorily associated with the diagnosis of open spina bifida. Indeed, in the event of one missing space, basically, so when there are only 2 out of 3 missing spaces and the ratio between the anteroposterior size of the brainstem and the distance between the posterior wall of the brainstem and the occipital bone is very narrow, actually, which basically means that the size of the brainstem is normal. And what is missing is not, in this case, the cisterna magna, but is the choroid plexus of the fourth ventricle. Actually, in this case, you have, as I said, a narrow brainstem to occipital bone ratio, and the fact that what is missing is not the cisterna magna, but because of its obliteration, but is the choroid plexus of the fourth ventricle. This means that this abnormality, this abnormal appearance, has been consistently associated with a diagnosis of cystic malformation of the cranial posterior fossa. So again, this is a normal appearance. This is the normal appearance of the mid-sagittal view of the fetal brain in the first trimester between 11 and 13 plus 6 weeks of gestation. This is actually the most conventional modality of insonation, because at this gestation, as I anticipated, we commonly we need this scanning plane to measure here the nuchal translucency. Actually, we now move on to another mid-sagittal view of the fetal brain in the first trimester, but using a different angle of insonation. In this other clip, I want to show you a very similar image, but in this case, the difference is the type of insonation. This is again a mid-sagittal view of the upper thorax, neck, and head with brain of a first trimester fetus. The difference is that if in the previous clip the insonation was from let's say directed from the bottom to the top of the head, in this case we have a frontal to opposite insonation, which is basically going from from the top to the back of the baby's head. And in this case, I would like to, as you can see, of course, you can see that we have a different appearance of the normal structures which we described in the previous clip. Of course, again, you can observe that the fetal profile is again normal. I don't want to spend a long time on this, but freezing the clip on a perfect mid-sagittal view, as you can see here, you can nicely see that for example, the three anechoic space which are present at the back of the fetal brain are no longer all anechoic, but in this case we have, for example, the brainstem, which indeed is not a fluid-filled space, but it's a tissue space. The brainstem is composed by cerebral tissue, so it's not definitely fluid-filled space, and it's not anechoic, using this different angle of insonation. And for example, also looking at the second line, which under normal, using the previous angle of insonation, represents the border between the fourth ventricle and the cisterna magna, which is basically, again, the choroid plexus of the fourth ventricle. Using this angle of insonation is no longer a line, but it is like, let's say, an ellipsoid structure, because, of course, on the mid-sagittal plane, actually, the choroid plexus of the fourth ventricle is not flat, but it's round-shaped, as you can see here. So basically, this is the one of the differences which can be observed between this different angle of insonation using the same mid-sagittal approach to investigate the fetal brain in the first trimester. Of course, this angle of insonation is less efficient in terms of visualization of the nuchal translucency, so maybe this is why we are less familiar with this type of angle of insonation, but I would like to drive your attention, just unfreezing and letting the clip run again, on the very high quality and high definition of the cerebral structure, of the cerebral structures which we previously defined. For example, you can nicely see here, this is again the diencephalon, but here anterior you have the anterior commissure, and you can see that its appearance is much crisper compared to the previous mid-sagittal view, which was obtained using a different angle of insonation. You can nicely see here anteriorly here the fornix, and overall you can nicely see that the border delimiting the encephalon, it's much more clear and much more defined compared to the different angle of insonation. And for example, at this point, if you want to freeze and measure the distance and the ratio between the size of the diencephalon and that of the cerebral falx, actually it is much better, and you're much more likely to be accurate using this angle of insonation compared to the conventional angle of insonation adopted for the measurement of the nuchal translucency. And in such context, I would like you to bear in mind that when you have an increased size of the diencephalon in relation to the size of the cerebral falx, this has been associated as an early indicator of agenesis of the corpus callosum. I'm sure you're all aware that the corpus callosum is not present at early gestation in the first trimester, but we will be discussing another indirect sign of callosal agenesis, which has been described in the first trimester, which can be evaluated using Doppler technology. In this case, we are not using Doppler, we're using grayscale ultrasound, using a high-frequency probe, and what we can see is the border between the diencephalon and the cerebral falx, and thanks to this, following the identification of this border, we can measure the relative size of the diencephalon and that of the cerebral falx. When the diencephalon is increased compared to the cerebral falx, this represents, this has been suggested as an indicator, an early indicator of callosal agenesis, because of the fact that the third ventricle has been reported to be increased in size and displaced upwards more cranially in those cases with callosal agenesis. I'm just going to unfreeze and move to more posteriorly. We have the mesencephalon here. We have already discussed about the posterior structures, which were discussed also in the previous slide. But moving from the diencephalon to the mesencephalon, I would like to drive your attention also on this structure, which is the Sylvian aqueduct. You will see that the Sylvian aqueduct is increased in size in the first trimester compared to later gestation. The Sylvian aqueduct can be seen on the axial and also on the coronal planes, but I'm showing here that the Sylvian aqueduct can be imaged with high accuracy also on the mid-sagittal plane using a slightly different angle of insonation, with the probe tilted slightly cranially compared to what we are conventionally used to do. And as you can see from this clip, the Sylvian aqueduct can be imaged with high accuracy, and here, of course, we know that the structure connects the third ventricle with the fourth ventricle. So I think we have focused on all the aspects of the expert neurosonology in the first trimester on the mid-sagittal plane, using more conventional and also less conventional angles of insonation. At this point, I'm going to hand over to Dr. Volpe, which is going to present another different angle of insonation on the mid-sagittal plane. In this case, we will not be seeing an anterior insonation, but a posterior insonation.
Thank you, Andrea. Now we can see the mid-sagittal views from a different approach. So this is a posterior approach, and we can see how the anatomy is quite different now. You can see some structures are looking different. This is the encephalon, and sometimes you see some black spaces in the encephalon, and this could be some fluid of the third ventricle. And you see how this is connected with the aqueduct of Sylvius, that is this black space here. And then you see this other black space here, that is actually the fourth ventricle. It is very nice to see how the brain stem is looking when you go through a posterior approach. And this is how the brainstem looks like. It is not so anechoic as when you see anteriorly, and usually you see three black spaces when you approach anteriorly, but here this is not really black. This is actually having an echogenicity that is more similar to the rest of the brain tissues, and you can see the curvature of the brainstem, that this is the midbrain curvature, this is the pontine curvature, and this is the medulla oblonga. So midbrain, pons, and medulla oblonga, and then you have just behind the brainstem, you have the two black spaces, aqueduct, here, in continuity with the third ventricle and fourth ventricle. The roof of the aqueduct of Sylvius is actually still midbrain, and this is simply the tectum of the midbrain. This is the tegmentum of the midbrain, and then sometimes you see like as a small line connecting the Sylvian aqueduct with the fourth ventricle, you see the isthmus, just this line here. So the fourth ventricle, while the aqueduct is very different from the second trimester, is much bigger, and this will shrink and become just a little line when you see the midbrain in the second trimester. The fourth ventricle still has its own shape, a C shape, with the upper part that is usually a rhombic shape, and the lower part that is just here is represented by the Blake pouch. So what happens is that you have the roof, the floor of the fourth ventricle, that this is actually the pons and the medulla oblonga, so the brainstem. And when you go, when you look at the roof of the fourth ventricle, the roof of the fourth ventricle is this one. So it is the membranous area. In the middle of the membranous area, there is this dot. This white dot is actually the choroid plexus on the mid-sagittal cut. And above the choroid plexus, you have the anterior membranous area, and below the choroid plexus, you have the posterior membranous area. The anterior membranous area is the area from where the vermis of the cerebellum will develop, whereas the posterior membranous area is just the roof of the brain, of the Blake pouch, and at some point during the development of the brain, this will fenestrate through the foramen of Magendie, and the foramen of Magendie will allow the passage of the fluid, of the cerebral fluid, to the external cisterna that you can start seeing here, that is the cisterna magna. Actually, if you just change your view in a slightly different gestational age, but if you go a bit from an apical approach, posterior apical, you can see a slightly different anatomy. This is a bit older baby. You see it is between 12 and 13 weeks, and you see actually how the anatomy could look different. You have still the encephalon just here in the middle of the brain, and then you can see very nicely the Sylvian aqueduct here. Probably this is the best frame. Sylvian aqueduct here. All right. The Sylvian aqueduct here, the midbrain tectum, the midbrain tegmentum, the isthmus here, and then you have the fourth ventricle. The anterior membranous area at this level is thickening already, and this is where the vermis will come from. And here you see a bit better that this is the choroid plexus of the fourth ventricle. This is the fourth ventricle, the C shape. This is the Blake pouch. This is the anterior membranous area, and here you have the posterior membranous area, and you start having some fluid behind the membranous area, that is the cisterna magna. Very nicely, you have the encephalon, midbrain here, pons, and medulla oblonga. And I think this is very clearly depicted mid-sagittal view from a posterior approach. And I think now we can go straight to the next session. Thank you for your attention.
So we now move on to the end of this piece on the expert sonographic assessment of the fetal brain in the first trimester. We've seen the expert assessment on the axial, sagittal, and coronal planes using 2D ultrasound, using high-frequency probes, which allow a very crisp definition of the cerebral structures in the first trimester. In this last part of the presentation, we'll be talking about Doppler technology. Actually, we will not be talking about conventional Doppler technology, but we will be focusing on, let's say, newly developed Doppler technologies with the particular property of being able to and sensitive for the identification of low velocity flows. And of course, this newly developed Doppler technologies at present, which are now available on high-end equipment, allow these days not only to image arterial structures but also venous structures such as the dural sinuses. So I'm starting again from the mid-sagittal view. In this case, as I said, we're using again a linear probe equipped with a Doppler technology which is highly sensitive for low velocity flow. What can you see on this plane? You can see arterial structures, and particularly you can see the pericallosal artery with all its branches, which can be seen high here, just anterior to the anterior commissure and to the fornix. You can see here. Why is it important to image the pericallosal artery in the first trimester? Because early studies conducted in the last decades demonstrated an association between the absence of the pericallosal artery in the first trimester and the later diagnosis of callosal agenesis. As I said in my previous part when I discussed the normal appearance of the cerebral brain on the mid-sagittal view, I anticipated the fact that the corpus callosum is definitely not present at early gestation. We are talking about here of 11 to 13 plus 6 weeks fetuses, and definitely the corpus callosum is not present at this early gestation. But talking about Doppler technologies, it is important you to bear in mind that at this gestation, if you don't see the pericallosal artery, a normal pericallosal artery, you have a consistent risk of later development of and later diagnosis of callosal agenesis in the first trimester. Talking about other arterial structures which can be seen on this scanning plane, you can look here. This is the vertebral artery going up and becoming the basilar artery, and we will be talking about later about what is another structure which is derived of the cerebral brain, vascular structure of the cerebral brain, which is derived by the basilar artery, which can be imaged using Doppler technology is highly sensitive for low velocity flows. Moving on to the venous structures which can be imaged using newly developed Doppler technology is highly sensitive for low velocity flows. You can nicely see here the superior sagittal sinus here. This is the straight sinus here, and I'm sure you all know that the superior sagittal sinus and the straight sinus join posteriorly in the torcular aerophyly. Why is this structure important? This structure is important, and also the straight sinus these structures are important because the torcular aerophyly and also as well as the straight sinus, anatomically they run just parallel, just on the top, on the roof of the tentorium cerebelli, and we know that the tentorium cerebelli is a structure which is crucial for the differential diagnosis of the malformations of the posterior fossa. And other than being crucial, it is also quite difficult to image in the second trimester, let alone in the first trimester. Talking about second trimester, our group described the importance of the Doppler assessment of the position of the torcular aerophyly in relation to a line running through the bony palate, which we call the transpalatal line, but actually this was described for the differential diagnosis of the malformations of the posterior fossa in second trimester fetuses. Actually, other authors described using the same rationale that of this anatomical relation between the straight sinus and the torco-rherophyly with the course of the tentorium cerebelli, described the use of Doppler technologies in the first trimester to define the position of the tentorium cerebelli under normal and abnormal circumstances. More specifically, a very important parameter was described. This was called the brainstem to tentorium angle, which is shown on this drawing. You can see that the brainstem to tentorium angle can be measured, drawing a line through the brainstem here and drawing another line through the straight sinus here. And under normal circumstances, this is an acute angle, but an upwards displacement of the cerebellum, of the tentorium cerebelli, which of course, as you all know, is associated with the cystic malformations of the posterior fossa, and particularly the highest displacement of the tentorium cerebelli is a feature of a severe malformation, which is called Dandy-Walker malformation. In this case, you can see that if you think that that in this case the tentorium cerebelli is upwards displaced, you can imagine that the angle comprised between the brainstem and the tentorium becomes more and more narrow until it becomes parallel, until the tentorium and the straight sinus runs parallel to the line drawn through the brainstem, and at this point we have what happens under conventional circumstances of an extreme upward displacement of the tentorium cerebelli, which again, as I anticipated, is a feature of the Dandy-Walker malformation. On the other hand, we have also conditions which are characterized by a downwards displacement of the tentorium cerebelli, and I'm talking about particularly of the cases of open spina bifida. We have anticipated that on the mid-sagittal view of the fetal brain, using 2D ultrasound with no Doppler, we can assess the three spaces at the back of the fetal brain and suspect, or let's say anticipate diagnosis of open spina bifida using parameters such as the brainstem to occipital bone ratio. In this case, if you want to describe the width of the brainstem to tentorium angle in conditions of downward displacement of the straight sinus and of course of the tentorium cerebelli, as it happens in the context of open spina bifida, you can imagine that in these cases you have an angle which widens compared to normal cases, and usually is around 90 degrees. So be aware that when you find this angle of around 90 degrees, please always move to the spine, try to image the spine on an expert fashion to diagnose an open spina bifida, which is highly likely, and of course in this case you may also you have also the opportunity to remove the Doppler technique and assess carefully the three anechoic spaces, if normal or abnormal, using conventional grayscale ultrasound. So now we move on from the mid-sagittal insonation to the axial insonation. You can see here a nice example of the circle of Willis. This is a vascular structure of the basic cranium, which is formed by three important vessels, which are represented posteriorly by the basilar artery and anteriorly by the two internal carotid arteries. These three vessels are can join through vascular anastomosis, which can be seen here in details. The basilar artery runs posteriorly and cannot be seen on this scanning plane, but runs posteriorly and vertically at the level of the basic cranium. It is formed by the junction of the two vertebral arteries. The two vertebral arteries join at the level of the junction between the medulla and the pons, forming the basilar artery. It again runs anteriorly at the level of the basic cranium and vertically, and the basilar artery branches into the two posterior cerebral arteries, which can be nicely demonstrated in this clip, one here and another one here. Then the two posterior cerebral arteries, they can join the blood coming from the internal carotid artery bilaterally by means of these two vessels, which can be seen one here and another one here, and these two vessels, they allowing the conjunction of the blood coming through the posterior cerebral artery and the internal carotid arteries are represented by the posterior communicating artery. Then where at the level of the conjunction between the posterior communicating artery and the internal carotid arteries, you have the onset of the two middle cerebral arteries, which can be seen here. They have no clinical implications in the first trimester, but they are important vessels for in fetal medicine, given their role in the diagnosis, for example, of fetal anemia or in the management of fetal growth restriction. And then again, the two internal carotid arteries join anteriorly through the anterior communicating arteries, which can be seen bilaterally here and here. And as you can see, the two anterior communicating arteries join themselves anteriorly, and at this level you can see the very most proximal part of the two anterior cerebral arteries, which run towards the frontal lobe and are responsible for the perfusion of the most anterior part of the brain. So I think we have shown very good examples of expert imaging using high-frequency ultrasound probes and also newly developed Doppler technologies. That is all from me, from Professor Ghi, and from Dr. Volpe. We do hope this educational video has been useful for you and for your knowledge, and we thank you very much for your attention.